Again, for anyone who's joined in, my name is Aisha Akhtar. I'm the Director of Education of EF Greater Chicago. And what better way to end tonight on a very positive, uplifting note? Our next session is entitled The Pipeline, New and Emerging Therapies for Rare Epilepsies. And as soon as I personally hear the word pipeline, there is one person that comes to mind, and that is Dr. French. She is one of my intellectual heroes. I don't even know if she knows this or not, but she is. And she is the Chief Medical and Innovation Officer at the Epilepsy Foundation and an epileptologist at NYU Langone Health. So she is going to share some really exciting updates on approved therapies for rare epilepsies and those in the pipeline. So thank you so much for being here, Dr. French.
Thank you so much for inviting me. And, I've been listening to these incredible stories as we're going along. And, uh, you know, I can only say that I absolutely agree that everybody needs to keep trying. And I hope that I give you some reason to believe it's worth continuing to try with what I have to share. So, everybody can see my screen.
Yes, you are good to go.
Okay, great. So these are my disclosures. There's a lot of companies on this slide, and that's because I work with a great deal of companies through the Epilepsy Foundation and the Epilepsy Study Consortium, which is another nonprofit in the field. And a full slide means that there are lots and lots of companies that are interested in developing new therapies for epilepsy. So I'm going to talk about a couple of themes tonight, from blockbusters to mini-busters, from anti-seizure medicine to disease-modifying epilepsy, and something that's already been raised, which is the concept of personalized medicine. So let's start off with from blockbuster to mini-buster. To Up until now, most drug development has been for what I call the common epilepsies, and you've heard a little bit about this before in terms of the different kinds of epilepsy. So the common epilepsies are focal epilepsy and idiopathic or genetic generalized epilepsy, and I'm going to go into that a little more in a couple of minutes. But together, those two syndromes actually account for 3/4 of all people with epilepsy. But many people, particularly children suffering from epilepsy, don't have common epilepsies. They have rare epilepsies. And as you all know, because that's why you're here, the treatments are not as good for the rare epilepsies. So I talked about the common epilepsies, which are the focal and the generalized epilepsies. The focal epilepsies are epilepsies where most of the problem really rests in one single area of the brain that is disrupted and has epileptic potential. Sometimes there's two or maybe even three small areas of the brain, and the seizures come from those areas, whereas the rest of the brain is functioning pretty well. The idiopathic generalized epilepsies are kind of interesting because the seizures actually come from what appears to be the whole network of the brain at once. That's why they're called generalized. They start everywhere. But indeed, between seizures, people again function quite well. And between seizures, they can go on and go about their business. There is a third group, and that is the group where most of the rare epilepsies reside. And they are different because not only do they have generalized seizures, because the entire brain network is disrupted, but they also have focal seizures. So they have combined generalized and focal epilepsy. And that's because in these cases, these rare epilepsies, now not all rare epilepsies, but a large portion of rare epilepsies are associated with what we call the developmental and epileptic encephalopathies. And you heard Dr. Dixon Salazar use that term already. That means that there are cognitive and other problems that are going on in the brain, and the brain is usually extremely disrupted. And Dr. Dixon Salazar mentioned a couple of reasons why that can happen, and Kim just mentioned another one. The whole brain can be deprived of oxygen, causing the whole brain to be disrupted. Um, it can be a genetic disorder that affects the entire brain. It can be a stroke or something that happened in utero, many different things. But it's this combination of the brain being disrupted throughout, which means that it can cause generalized seizures, or different parts of the brain can be excitable and focal seizures can happen. That means that the drugs that we choose for people with the rare epilepsies have to be somewhat different than the drugs that we choose for the focal epilepsies or the generalized epilepsies. So if you look at the drugs that have been approved since 2018 to 2020, I have actually color-coded for you. The common epilepsies are the ones that are in red or in blue. These are the drugs that were approved recently for the common epilepsies. The rare epilepsies are the ones that are in green. And you can see that the slide is pretty full of drugs that were approved for rare epilepsies, and we'll talk a little bit about them each in turn. So, as I mentioned, drug development really has completely turned around from the time when there was a big focus on the common epilepsies, which maybe are less complicated to treat, and now the focus is on the rare epilepsies. So that's what I mean from blockbuster to mini buster. Let's not try and cure everybody or the majority of people, but let's have these small targets that we can go after. So orphan indications and orphan diseases are the same as rare diseases. The definition of an orphan disease is one for which there are less than 200,000 cases in the United States. They are the new brass ring, so to speak, for companies to go after. And the idea of treating orphan epilepsies has brought many new companies into the epilepsy space, and that actually includes some biotechs and small pharma and startups, as opposed to in the old days when it was the very large pharmaceutical companies like the Pfizers and the Glaxo Wellcomes. We all know Pfizer now because of COVID, that were going after epilepsy. So why, in fact, are the pharmaceutical companies now suddenly so interested in the rare epilepsies? Well, for one, as you heard, there's more chance that the underlying cause for the seizures is known, and we'll talk a little bit more about that later as well. The marketplace was not crowded. Now it's getting a little more crowded as people are coming up, as you will see, as people are coming up with more potential treatments for certain rare diseases. I am excited to say, and you've heard a lot about this as well, that there are patient and parent groups that are very energized and excited to help and motivate and speed development. In addition, rare and orphan diseases get special benefits from regulators, specifically the Food and Drug Administration, that are intended to motivate drug development, because there is a feeling that if these special benefits were not available, perhaps there wouldn't be incentive for companies to go after these rare diseases. And unfortunately, the last part, many of you probably have also experienced, and that is the justification that if there are only a small number of patients with the disease and there was a large cost to the development, then the drugs can thereby command a premium price, and some of the drugs may cost up to $200,000 a year, down to about $30,000 a year for the quote unquote cheaper ones, which obviously are not so cheap. So the fact that these drugs are very expensive is something that is unfortunate, and we have to keep in mind. So an example of a rare disease that has drawn a lot of attention from people who are developing new therapies is Dravet syndrome. So in 1978, one of my heroes, Dr. Charlotte Dravet, noticed that some children with epilepsy had a similar age of onset of seizures, about the first year of life, that their seizures seemed to be not like the other children. They were quite stereotyped, and they were hemiclonic convulsions, meaning that the children would seize on one side of their body and not the other, whereas most children seize on both sides. The seizures were more likely to be precipitated by fever, and they were more likely to be prolonged, and the prognosis for these children were poor, and eventually they ended up with developmental delay and very bad seizures, and they also had a high risk of death from sudden unexplained death. She looked at all of these, and of course, people had been looking at these children for 100 years, but nobody had noticed that there was these similarities. And she was the one that identified it and said, I think that this is a syndrome. So we now call it Dravet syndrome after Dr. Charlotte Dravet. And 40 years later, amazingly, it was discovered that Dravet syndrome was actually caused by a single gene mutation in the SCN1A gene. And so what she clinically discovered actually was a group of children with a genetic mutation. And now that we know that that mutation exists, that allows us to create genetic animal models that then can be used in the laboratory to test drugs and to find new therapies. And that's one of the reasons why Dravet syndrome has gotten so much emphasis in regards to new therapies. So if you look at the drugs that were recently approved for orphan syndromes, and we've already heard a little bit about cannabidiol, which is one of the medical marijuanas from Kim, that has been turned into a therapy called Epidiolex. It has been approved initially for Dravet syndrome and also Lennox-Gastaut syndrome, which we heard about from Dr. Dixon Salazar, and finally seizures associated with tuberous sclerosis. Fenfluramine has been approved for Dravet syndrome. Afinitor has been approved for tuberous sclerosis. And then there are some new therapies that are approved for what many of the rare epilepsies have in common, which is cluster seizures. And we already heard about that, and trips to the emergency room. So it's really good that there's new therapies in that area. And then finally, diacomit or stiripentol, again for Dravet syndrome. So you see Dravet for 3 of the 4 new drugs that are not rescue therapies. And I'm going to just talk a minute about each of these new therapies that currently is on the market. And we're going to start with talking about Epidiolex. And I think Kim, sort of set the stage for this because I'm going to talk about probably the little girl that she saw that was on the television screen, and her name was Charlotte Figi. She was born in 2006, and I'm sure that many of you have heard, unfortunately, that she passed away during the COVID epidemic. But Charlotte Figi was diagnosed with Dravet syndrome, and as an infant started to have hundreds of seizures a month. And here you can see her in the middle of a seizure. And for whatever reason, her family decided to give her a strain of medical marijuana, which was high in CBD, which is the part of the medical marijuana that does not cause hallucinations and does not make you feel high. So she started that at the age of 5, and she got dramatically better, starting to have instead only 2 to 3 seizures a month, which were all happening at night. And here's Charlotte again. And because of the incredible improvement that happened in Charlotte, people started growing a form of CBD that was just for her, and it was called Charlotte's Web. And I'm sure many, if not all of you, are familiar with Charlotte's Web. That caught the eye of a company in England that had already been growing marijuana for the purposes of turning it into an actual pharmaceutical drug, and that was Greenwich Pharmaceuticals. They were actually at that point more interested in THC, which was being used for pain, and that is the part of the plant that causes hallucinations and a high feeling. But they immediately turned their attention to CBD, which seemed to have a significant impact, at least in Dravet syndrome, and perhaps in other seizures as well. They did some open label studies, and eventually they did what we call a randomized placebo-controlled trial. And in order for us to really know whether a treatment works, we have to compare it, because people, when they go on a new therapy, they can get better, but they can also have a great deal of hope. Who wouldn't? Um, and sometimes that hope can turn into a reduction in seizures, or sometimes in some types of epilepsy, you can actually have a spontaneous remission. So we want to know what would have happened if you hadn't gotten the treatment as well as if you had. So we give a sugar pill, which we call a placebo, and compare it to half the kids, and we give the drug to the other half of the kids, and we compare the result. Now, this is a little bit of doctor talk and it's a little confusing, but what you're seeing here is the outcome of giving children CBD or Epidiolex, and this was children with Dravet syndrome, for their hemiconvulsive seizures that are so typical for that particular syndrome. And you can see that, as I mentioned, children who just get a sugar pill or placebo actually do get better also. So this is the percent reduction in seizures that happened during the trial. And you can see about 15% of the children, or there was about a 15% reduction in seizures just from the sugar pill or spontaneous reduction. However, the children who got the Charlotte's Web equivalent of Epidiolex actually had more like a 40% reduction in seizures. So that was a big difference. There's a big difference between this blue bar and the green bar. And when you looked at all the other types of seizures that they were having as well, it wasn't quite as successful, but still did cause a reduction in the other seizures as well. And this was the first pharmaceutical treatment for Dravet syndrome, and really started off the trend of developing new therapies for people with orphan syndromes. It was such a big deal that it got published in the New England Journal of Medicine, which is a very, very big deal, not epilepsy journal, but journal for all doctors to read. They then went on to do another study in Lennox-Gastaut syndrome, and again saw, here you see even more of the children who were given the sugar pill in green having a reduction in seizures, about 22%. But again, the children who got the actual medicine did much better, having, somewhere between a 45 and 50% reduction in drop seizures, and a similar reduction in non-drop seizures in Lennox-Gastaut. Even some children became seizure-free, not that many, but some. So the open label studies that were done before the placebo-controlled trials, there was about 8% of the children who became seizure-free. And when we have that comparison group, we find that like 0.5% of the children who were randomized to the placebo became seizure-free, but again, about 8% of the children who were randomized to Epidiolex became seizure-free. So it's a little better than that 3% that Dr. Dixon Salazar had mentioned before. And certainly for those children, it's life-changing. But I hate to burst the bubble that it's natural and therefore doesn't have side effects. Unfortunately, Kim and everybody else, it does have side effects. And some of them are quite significant, and did lead to having to stop the medication. This was not as well known in the beginning when mothers were giving their children CBD as Charlotte's Web as it is known now. But if you look at the difference between the children who were taking the placebo or sugar pill, which is really how you can know that it's related to the drug, and the likelihood of those same things happening for the children who were taking CBD or Epidiolex, you can see that, let's say, 8 to 10% of the kids on placebo were having sleepiness and diarrhea and decreased appetite and vomiting. But these things were much, much more common in the children who were taking the Epidiolex. And even some of the children had abnormalities in their liver function tests, and they had to be taken off the drug. This was particularly true when the drug was given with valproic acid or Depakote, and we know to be very, very careful when that combination of drugs is used. Another thing that happened is that and I'll talk a little bit about this, when Epidiolex or CBD is given with clobazam, which is the trade name is Onfi, which is a benzodiazepine, the kids could get very, very, very sleepy. And sometimes they got so sleepy that they aspirated and ended up in the hospital. So that is another combination that we have to be very, very careful with. However, there's a yin and a yang in regards to clobazam. So clobazam is a medicine that's commonly used in these children with developmental and epileptic encephalopathy, combined focal and generalized seizures, because it treats both focal and generalized seizures very well. So actually, a lot of the children who were in these studies were on clobazam. What it turns out is that Epidiolex or CBD slows the exit of clobazam and its metabolites from the body. So whereas it, might go out, the whole amount might go out in the course of a day, it was hanging around in the body instead. And therefore the amount in the brain was going up and up and up. This leads to two things. I already talked about one of them, which is that the kids can get very sleepy. But on the other hand, that combination of increase in the clobazam and, boosted by the Epidiolex actually was very important in getting the seizures to go down too. So in the open label studies, if children happened to be on clobazam when they were in the study, they were much more likely to have a 50% or more reduction in their seizures than the children who were not on clobazam. And it turns out that 65% of the 120 children in the Dravet study and about half of the children who were in the Lennox-Gastaut study were receiving clobazam. And we don't know exactly how much that contributed to the benefit that the children saw. But interestingly enough, the European Medicines Agency looked at all the data and they only approved the drug in combination with clobazam. So they saw that this impact of Epidiolex was much, much greater in the children, or much greater, I don't want to say much, much greater, in the children receiving clobazam than in the other children. And that is not to say that Epidiolex and CBD do not work in children that are not on clobazam, but a lot of the profound effects and seizure freedom and so on are seen in the children who are receiving clobazam. And interestingly enough, another medicine, stiripentol or diacomit, also works much better in children who are on clobazam for the same reason. So after the success of Epidiolex, the next drug to come along was fenfluramine, and that is now on the market. And you may have heard of fenfluramine. You may have heard of a drug called fen-phen. Fen-phen was a drug that in the 1980s was all the rage because people were using it as a weight loss drug, and it was prescribed by doctors as a weight loss drug. It was a combination of fenfluramine at a reasonably high dose with another drug called phentermine. That combination turned out to be quite dangerous. It caused pulmonary fibrosis, that is, fibrosis of the lungs, and it could cause thickening of heart valves. And both of those things, in fact, could in some people be fatal. So the drug was quickly taken off the market. However, during the time when it was being developed, people were looking at fenfluramine in children with severe epilepsies, and there was a small group of children who were started on it 20 years ago, got profoundly better and remained on it, and some of them are on it to this day. Based on that, a company said, well, let's see if we can take a much lower dose of just one, that is fenfluramine, not the combination. Let's see if it's safe, and let's see what it does in Dravet syndrome. And lo and behold, I just showed you the Epidiolex results, but these results are really, really impressive. So this is 3 bars now instead of 2. The gray bar is the sugar pill or the placebo. The blue bar is a middling dose, a middle-sized dose, and the green bar is not a high dose, but it's a higher dose. It's still only 0.8 milligrams per kilogram per day. And they did a trial in Dravet, and you can see that the children who got the highest dose had 70% of them had more than 50% reduction in seizures, and half of them had more than 75%. That is, 3/4 of their seizures went away in half of the kids, which is like pretty amazing. And this drug is now on the market for Dravet. And there are a lot of children with Dravet who are substantially improved after being tried on this drug. But, we have to keep in mind that it did cause this heart valve thickening and pulmonary fibrosis in the adults who took it for weight loss. So the FDA said, there's no evidence of this in children. We think it's safe to approve, but you have to keep watching these kids. So kids who go on this drug need to have an echocardiogram of the heart at intervals just to make sure that nothing is going askew with their heart valves. But so far, so good, and the children are doing well. Moving on to tuberous sclerosis. Tuberous sclerosis is unchecked growth of cells in the brain, again, due to a genetic mutation. And you can see in this picture some small areas of tissue and lumps and bumps that happen in the brains of children with tuberous sclerosis. And those lumps and bumps in about more than 90% of the kids, unfortunately, lead to seizures, but they also can have growths that can cause other problems in the brain and also in the rest of the body. And all of this happens because of a disruption in something called the mTOR pathway, which is a signaling pathway in the brain that regulates how cells grow, differentiate, and multiply, not only in the brain, but in the rest of the body as well. So gene mutations which causes tuberous sclerosis, and also something else called cortical dysplasia, which is another cause of epilepsy. Cells grow out of control. And this drug, everolimus or Afinitor, was actually on the market to treat kidney cancers and make those growths go down. And it was found that this drug works on the mTOR pathway. And it seemed like a reasonable thing to do to try it in kids who were having problems with these big tumors due to tuberous sclerosis, and they're called giant cell tumors. And here you can actually see that this is the same child here with a big lump in their brain in the A panel, which after Afinitor became a little tiny lump in the B panel. Well, when they were treating these giant cell tumors, they were like, wait a minute, these kids had seizures and now their seizures seem to be getting better. Could this also be a way to treat their seizures if we are, even in children who don't apparently have these big lumps in their brain? So they did a study, and now you can see the placebo or sugar pill is in orange, and then the middle dose of the drug is in green, and the higher dose is in red. And you can see that, again, there was about a 15% reduction in seizures with the sugar pill versus a 40% reduction in seizures with the highest dose of Afinitor. So yes, it does make the seizures go down in children with tuberous sclerosis. And this is actually a bit of a novel and exciting advance, because most of the drugs, which I'm about to talk about a little more, that we use to treat epilepsy are not specific for what's wrong with you. They don't actually target the brain areas that are causing the seizures, whereas everolimus goes right after that mutation in the mTOR pathway specifically corrects that problem and thereby reduces the seizures. So it's a whole new world of brain therapy this is the first example of. The more we, and Dr. Dixon Salazar said this, and I'll say it again, the more we actually understand what's causing seizures in the brain, the more we can fix it. Again, this drug does have side effects. One thing is that it knocks down the immune system a little bit, so you have to look out for infections. And also it can cause some rather uncomfortable sores in the mouth, stomatitis. They can be treated and kids can stay on the drug, but it can be uncomfortable. And the nice thing about Afinitor is that it doesn't only treat the seizures, it treats some of the other problems that happen because of this gene mutation. So these individuals can get small little tiny bumps on their face, and you can see this young lady with little tiny bumps on her cheeks, which are facial adenofibromas. They can get kidney tumors, they can get the giant cell astrocytomas. So the fact that you can take this drug and not only treat your seizures, but treat the other things that are going wrong, this is what we want in other treatments for epilepsy. And just to say a few words about rescue therapies, because I think that they are super important, and I hope everybody who's on this call has a rescue therapy at hand. So what is a rescue therapy? It's a treatment that's not given every day, but can be used to stop a cluster of seizures or treat when the risk of a seizure is higher than usual. And you use it as needed to stop seizures that are different or longer than the usual seizures that happen, or seizures that are happening in different pattern. And it's a very important tool that we use to reduce the need for an ambulance, which is even worse in COVID times, of course, emergency room or hospitalization. And you can think of it kind of like an EpiPen for seizures. And we have several, it used to be that we only had rectal formulations, rectal diazepam or Diastat, and now just in the last couple of years, that has been joined by a number of much easier to use therapies, a nasal midazolam called Nasolam, a nasal diazepam called Valtoco, and something that you can just tuck under the cheek, a buccal clobazam called Sympazam. And I just have to talk about another exciting new therapy that's in the works, which is inhaled alprazolam. And the reason that that is exciting is because it gets inhaled. It's a device that you can see here. And if you put an individual having a seizure in front of that device and they just breathe in a normal breath, it activates the inside of the device, it heats up and makes a gas that then is inhaled by that individual. And the lung is an enormous amount of space to absorb a drug. So instead of taking 10 minutes, as the other rescue medicines can take before the seizures stop, and those 10 minutes, if you're a parent, I don't have to tell you guys, is the longest 10 minutes of your life, this may actually work in as little as 30 seconds. So that's very exciting. That's in development, and there are trials that are going on right now for inhaled alprazolam. So I've taken you through the drugs that are now available, but there are many more drugs in the pipeline for many orphan syndromes. So for Lennox-Gastaut syndrome, we have soticlestat that actually works on cholesterol in the brain. Fenfluramine, which you saw was approved for Dravet, is also in development for Lennox-Gastaut syndrome. They already did a study which was successful. And there's another drug, charisbamate, that's also in development for Lennox-Gastaut. Dravet syndrome, soticlestat, which I already mentioned, and then two drugs I'm going to talk a little more about, STK-001 and ETX-101, both of which are gene modulators. So again, going after genes. There are drugs for Lafora body disease, which is a terrible and progressive myoclonic epilepsy. Another drug that works even better, perhaps, on the mTOR pathway for tuberous sclerosis. There are two drugs that are for a very rare epilepsy called SN8A encephalopathy, which is due to a mutation in the SCN8A gene. There is a drug ganaxolone that is in development for CDKL5. There is a drug in development for Rett syndrome, and a drug for KCNQ2 encephalopathy. So many, many, many rare syndromes are getting a lot of love. So I already sort of raised this concept from anti-seizure to anti-epilepsy drug, but I want to delve into it a little more because I think that it's super important and it follows up on some themes you've already heard. The International League Against Epilepsy, which is our sort of international parent organization for doctors, is considering very strongly changing the name of what you've often heard talked about as an anti-epileptic drug, AED, anti-epileptic drug. And the reason is that most medicines are not actually anti-epileptic. They are anti-seizure medicines. That is, they don't treat what's causing the epilepsy. They just treat the seizures. So the example here is if this poor little guy has pneumonia, then you could give him an antibiotic and treat his pneumonia, or you could give him a cough medicine and he wouldn't have his cough anymore, but he would still have his pneumonia. And all of you know very well that the medicines that we give are treating the seizures like treating the cough, but you still got the epilepsy. And if you stop the drugs, the seizures are going to come back. So to repeat, the drugs now available, again, with maybe the exception of Afinitor, are actually anti-seizure drugs. They don't act to stop the cause of the seizures or work to prevent future seizures. But as we gain a better understanding, as we did with tuberous sclerosis, of what causes seizures, and you heard from Dr. Dixon Salazar that 50% of the time we don't know what causes them, but we're working on that, we might be able to treat the root cause. And that could lead to disease-modifying treatments, so you're treating the pneumonia instead of treating the cough, which is very unsatisfying for all of us. Now, I've had this cartoon for a very long time because I wanted to remember to talk about what about everyone else. I've talked about, all these different rare diseases that are due to gene mutations or other things. You've heard over the course of the evening about named rare diseases, but not everybody has a named rare disease who has an epileptic encephalopathy. And this doctor is telling this man, unfortunately, there's no cure. There's not even a race for a cure. And so if we don't know what you have, how can you join an organization of other people who have that same thing? And what about all of this development of drugs for people with rare epilepsies? That can leave some people outside of the umbrella. People who have no drugs being developed for them, who do have developmental and epileptic encephalopathy because they don't have a name to their syndrome. So we need to work harder to get everyone under the umbrella, because anti-seizure medicines that, maybe we don't know what caused your epilepsy, but an anti-seizure medicine that treats the symptom can still work and sometimes can work extremely well. And in fact, there is a lot of work going on making better and better and more effective anti-seizure medicines. So the Epilepsy Foundation actually just had a large meeting with a bunch of other constituents with the FDA to discuss whether we can do trials in people who have developmental and epileptic encephalopathy with combined focal and generalized epilepsy who don't have a syndromic diagnosis. So I just wanted to raise that for you guys. So now I'm going to talk a little bit about personalized medicine. So all of you have had this frustration, and I've heard that in all the people who have spoken tonight. You go into the doctor and they pick a drug, right? They say, well, try this one. I don't know whether it's going to work. If this one doesn't work, maybe the next one will. If that doesn't work, maybe the next one will. Because when they look at you, they, whether you're, tall, short, fat, thin, whatever age you are, in regards to drug response, you kind of look like this. Whereas what we want you to do is look like this. We want you to be lit up with all different kinds of characteristics that say, this is the drug for you. I'm not just going to try any old drug. So I gave the example of, you've got tuberous sclerosis. Let's give you Afinitor because that works in tuberous sclerosis. It works on the mTOR pathway. Maybe you have a gene defect. I know a drug for that. Maybe you have another type of epilepsy, but it seems that the drug lamotrigine works best in that type of epilepsy. That is personalized medicine. Choosing the next best therapy should be more than just an educated guess. So it's also known as individualized medicine, or you've already heard the term tonight of precision medicine. And really it boils down to, rather than picking the same first choice for everyone, use all the data you have to select the optimal choice for each person. And it's not the same for everyone, it's different for everyone. So this comes down a lot to genetics, but it's not all about genetics. So we do pick drugs based on other things we know about you, your age, your sex, your weight, your comorbidities, but genetics helps a lot. Genetics helps a lot. So let's talk a little bit about genetics. You've heard the word mutation multiple times. So some epilepsies are caused by genes that have errors or mutations, and I already talked about Dravet syndrome. So normal genes, many of them are meant to produce proteins that then act as building blocks in the brain. And if you have a mutation in a gene, then that building block either comes out as an unrecognizable blob that doesn't help, or maybe no protein at all is created. And if this goes on over a long period of time, the brain is just going to get worse and worse and worse as there are no building blocks that are able to build it up. So in some cases, if you have one normal gene and one mutated gene, you're okay because this normal gene is going ahead doing its business and the body can't really figure it out. But unfortunately, in other cases, and this is called a haploinsufficiency disorder, you really need 2 times the protein here. You're only getting 1 times the protein, and that is causing the problem. So that is true in Dravet syndrome, for example, where you have a normal gene, you have a mutated gene, and that is enough to cause a very severe problem in the brain. This is an example of what we call a monogenetic epilepsy, where one gene is mutated and causing the problem. And you already heard from Dr. Dixon Salazar that it's not always just one gene. There are many polygenic epilepsies. They're really hard to figure out, and I really give her enormous kudos for the fact that she figured out for her own family that there was a polygenetic issue. But it's much easier when there is a monogenetic cause of epilepsy, a single gene, that's the problem. And you can see that in the early 2000s, we knew about some channelopathies. SCN1A is here that causes Dravet. But now with next generation sequencing, we are just skyrocketing in the number of genes that we know about that can cause epilepsy, and they're just coming 1 a week practically. So when we're talking about precision medicine, there are tiers of precision medicine, and I took this from an article that's in Press. The first one is, are there drugs that we know that there's a recognized response to that drug in certain syndromes? And the best example that I can give you is what I just told you, that it looks like fenfluramine and probably Epidiolex have a very specific effect in children with Dravet syndrome. So that is, we don't know why. We don't know why it has that effect, but we sure are happy that it's there. So that's still precision medicine. We know what drug is good for you. The second level is that we know that there's well, actually that's the second level. The first level is a little below that. It's just our anti-seizure drugs working better in a syndrome. The second level is we know it's a genetic syndrome, and we know that a drug works in that genetic syndrome. The third level, which we already talked about, is we know the dysfunction of the gene, and we know a treatment that actually targets the dysfunction in that gene. The fourth level is the one that we are about to embark on, and that is that we are actually trying to fix the problem in the brain that is caused by that mutated gene, or we're actually replacing the gene in the brain. So how are we doing that? Well, one way that we are doing that, and trials actually recently started on this, is what we call an antisense oligonucleotide. And that is a very complicated thing, which I'm going to try and make less complicated. I already told you that in Dravet syndrome and several other of these mutation problems, there's a healthy gene that's spitting out nice healthy protein, and then there is a sick gene that is spitting out protein that is just garbage junk, that's just gunking up the works. So what if we got that bad gene to stop making that bad protein? We got rid of that bad protein, and then we just had the healthy gene making the good protein. Well, in that case, the healthy gene, for whatever reason, starts to make more of the good protein, and it starts to replace the bad protein. So you're basically stoking up the ability of that healthy gene, chromosome, that healthy chromosome, to make the proper protein. And hopefully that will allow the brain to develop normally, particularly if you can get in early before all the bad protein has sort of gunked up the works. This, however, does need to be given through a spinal infusion, and that spinal infusion needs to be given on a regular basis every few months. We don't know exactly how many months, but probably every few months. So, upside, you're actually fixing what's wrong in the brain. Maybe that will not only stop the seizures, but stop the other problems that are caused in Dravet syndrome and other haploinsufficiency syndromes. And the children may be able to grow up much more normally. As I said, clinical trials have recently started, and you can find out more at stoketherapeutics.com. Another company that's now in the space and working on this problem is a company called Encoded. And what they're doing is they're using a virus called the adeno-associated virus, and you may have heard about this on the news. That's a very bland virus that doesn't cause any kind of illness whatsoever, but is able to, once in the brain, go into the DNA and actually repair the part of the DNA that is causing the problem. So it's actually getting in there into the DNA to increase the activity of the patient's own SCN1A gene. Now, this particular therapy is not put in by spinal infusion. It's actually put in directly with a small burr hole in the brain temporarily. But once the adeno-associated virus and its payload goes into the brain and goes to the cells that are disrupted and corrects those cells, that is a one-time thing. So yes, you need to go into the brain. Yes, you have to use an adeno-associated virus, which now is being used in other conditions as well, quite successfully. But at the end of the day, you then hopefully have a brain that is fixed, and after that, the child just goes on and hopefully has better development and fewer seizures. And clinical trials of this are starting in late 2021. So in conclusion, this is an exciting time full of innovation. Disease-modifying therapies really are right around the corner. And we at the Epilepsy Foundation are really laser focused on research that will make a real difference for the rare community and all people with epilepsy. And thank you. I'm sorry that it's so late and you're still listening.
Well, because this is such riveting information. This is exciting. I've definitely taken notes. So thank you so much. And yes, the Epilepsy Foundation, I put in the chat the URL to the tracker for the pipeline information. So definitely check that out. This concludes day one. I'm going to turn it over to Glenn in just a moment, but I just wanted to thank everyone for being here. And I think that Dr. French, you really synthesized everything that we heard tonight, starting from Dr. Dixon Salazar's journey, going into Dr. Burdett and Dr. Warnicki's treatment options, hearing this really positive, uplifting story by Kim, and then you sharing like all of the things that are in the pipeline for the future. So there's a lot of exciting things in the works, and I hope that all this information people can marinate overnight and come back tomorrow and ask more questions. And before I turn it over to Glenn to close us out, I did want to mention that for all the participants, we will be sending out an email early next week, and we'll have contact information for all of our speakers so that you're able to look up more data, look up more research, and get in touch with everyone. So with that, I'm going to sign off and pass it over to Glenn to close us out for tonight. Thank you.
Well, what an exciting evening we've had of amazing presentations, Dr. French. It's so good to see you again. Thank you for the optimism and the drive that you bring to the work on behalf of all of us at the Epilepsy Foundation. Thank you as well to all of our wonderful speakers. We hope all of you have learned something tonight. I know I surely have. Now, I want you to direct your attention to the chat box where you'll find a link to your evaluation questionnaire. Please open the link. You can do that right now. Go ahead and open the link and take a moment to complete the evaluation as soon as you leave. Your feedback is very important to us. We hope that you'll join us tomorrow morning, starting at 10 a.m. Eastern time. That's 9 a.m. Central time. Or if you're coming in from one of the other time zones, I'm sure you have the ability to adjust accordingly. And we are really looking forward to an exciting day 2 of our conference. There are some great sessions and speakers lined up for you. And so we want you to have a good evening, rest up. Thank you to everybody for being here. We hope that this has given you some sense of what the opportunity is to improve the lives of those impacted by rare epilepsies, and hopefully some solace for you parents and caregivers to children and young adults challenged with rare epilepsies. Signing off here tonight in Minnesota. Thank you all for joining us tonight for the Upper Midwest Rare Epilepsies Conference. We'll see you tomorrow.